We can start the meeting. Dr. Divyesh, you can come on the screen. Good morning, everybody. Welcome to the Saturday morning meeting. We are back again after a gap of one Saturday when we had our GMA-con, that is Gujarat IMA conference last Saturday, so we could not hold the meeting. Today we have very interesting topic about radiation therapy. This is one subject which we know much about as being used modality for treatment of cancer, but we hardly ever actually come across any lectures related to know some basics about radiation therapy. Unfortunately, we have Dr. Divyesh Rana with us, who is working as Associate Professor in Radiation Therapy Department at Government Medical College and SSG Hospital. And thanks to Dr. Tushar Choksi, who recommended his name as our guest speaker. And thank you, Dr. Divyesh Bhai, for accepting our invitation to be our guest speaker. The session is open to you for about 40-45 minutes of your talk. And we'll have some interaction for 10 minutes or so. So over to you, Dr. Divyeshkumar.
Good morning, everyone. Working as an associate professor.
Your voice is cracking.
Our well-known SSG was opportunity to. Okay, just a minute. Now it's clear?
Yes, yes.
Okay. Thank you, sir, for giving me an opportunity to present myself and our well-known hospital, that is SSG hospital, in which our radiation oncology department is situated, where we are treating that poor class cancer patients who need best quality of treatment at our center. First of all, I would like to present that what is radiotherapy, how it is worked, how it is used, and in which cases radiotherapy is first of all indicated. So coming to my presentation, is it showing to everyone?
Yes, yes, yes.
Okay, okay. Then first of all, introduction, that is radiation has been an effective tool for treating cancer for more than 100 years. And the radiation oncologists are the doctors that are trained to use radiation to treat cancer patients. And about 2/3 of all cancer patients will receive radiation therapy as a part of their treatment. So to see the history, the first patient was treated with radiation in 1896, and that is 2 months after the discovery of the X-ray. And the rapid technology advances began in the early 1950s with cobalt units and followed by linear accelerators a few years later that are used nowadays in every centers. And the recent technology advances have made radiation more effective and precise to cover the target and sparing the normal tissues. Then what is radiation therapy? How it works? So it works by damaging the DNA within the cancer cells and destroying their ability to reproduce. So when the damaged cancer cells are destroyed by radiation, the body naturally eliminates them and kill the tumors. But normal cells are also affected by radiation, but they are able to repair themselves. Sometimes radiation therapy is the only treatment a patient needs, and other times it is combined with other treatments like surgery and chemotherapy. So the objective of radiotherapy is, if we are using radiotherapy to cure the cancer, it is called curative radiation, in which it destroys the tumor that have not spread to other parts of the body. That is, it is a local lesion. And it reduces the risk of recurrences in post-operative cases. So we can extend the patient's life. And when the intention of the radiation is to reduce the symptoms like pain and tumor size, so it is called radiation palliative radiotherapy. So according to name suggests, it shrinks tumors, so it is improving the quality of life. Like a lung tumor, when it causes shortness of breath, when sometimes in case of bleeding tumors, we can use it as a hemostatic radiation therapy. It also decreases pain and by reducing the size of the tumor. Who are included in the radiation oncology team? That is doctors, radiation oncologists, then medical physicists who ensures that complex treatment plans are properly tailored for each patient. The others are dosimetrists who works with the radiation oncologist and medical physicist to calculate the proper dose of radiation given to the tumor. Others are radiation therapists who administers daily radiation under the doctor's prescription and supervision. And then final, the nursing staff who cares for the patient and family by providing education, emotional support, and tips for managing side effects. Radiation can be given in combination. Sometimes it is given pre-operatively, that is to kill the tumor cells, to prevent metastasis, and to reduce the tumor volume. Sometimes it is given concurrently with a low-dose chemotherapy, and sometimes it is given post-operatively, that is given after surgery to destroy residual tumor elements or to reduce the chances of recurrence. It is given within 3 to 4 weeks after surgery. Then what are the radiation therapy timings? So it can be given in a single fraction treatment when it is used as a palliation or as a hemostatic RT. And most of the times it is given in the fractional method. That is, the tumor is irradiated for a few days or a weeks, and the total dose is divided into separate fractions. That is 2 gray per fraction or 1.8 gray per fraction according to the site size of the tumor. There are 3 different timings that are the pre-radiation time, during radiation time, and post-radiation time that we have to see during the treatment. The pre-radiation time is where we are taking the detailed examination of the patient, verification of the diagnosis and histological examination of the tumor, determination of the indications and contraindications of radiation therapy. Sometimes when there is a case of esophagus with involving the trachea, so it is a major contraindication to give the RT because it can cause a tracheoesophageal fistula. Or sometimes when in case of cervix, if there is an bladder involvement or there is an rectum involvement, by giving radiation, it can cause a rectovaginal fistula or vesicovaginal fistula. So in that cases, radiation treatment is contraindicated. So we have to decide it is before giving the radiation. Then it is choosing the method, that is it is when it is the intention of curative treatment or palliative treatment, and pre-radiation preparation. So when when we will give in cervical patients and or pelvic tumors, we have to measure strict bowel bladder protocol. So there is a minimum movement of the tumor during the treatment of the patient. This is the pre-radiation period. First of all, we are taking the patient's CT scan, which is available in our SSG hospital. It is 4D CT simulator. By taking the CT scan and with laser markers, we can plan. This is that white one is immobilization device. So we are planning CT scan and make a tattoo and put a marker, fiducial markers on this laser intersecting point. And after that, our physicist and doctors first will contour that this is the eyes, this is the tumor, this is the parotid. In case of head and neck, in case of breast, this red one is the tumor. And the physicist will plan according to the this colored area is our area of interest where we have to give proper dose, and we have to spare these lungs and the opposite breast and heart, and according to physicist and dosimetrist they plan. And we may maximum given dose to the tumor and sparing the normal tissues. This is a case of head and neck, brain tumor where the single field is given and the target is fired with radiation. This is the head and neck tumor, which is centrally located and better planned with IMRT. And this is the 3D view, which shows that if tumor is located in the center, the plan is like the beams are firing from different angles. So we can target the main location with maximum dose with giving minimum dose to the periphery area. So it is the pre-radiation period, which was planned. During radiation period, it is given for 1 week to 6 weeks according to the plan of the patient, and the patient is managed according to the symptoms related to the radiation toxicity. And in post-radiation period, effectiveness of the treatment outcomes, prevention and treatment of radiation reactions, and that are skin reactions or mucositis or any cystitis or proctitis will be managed. And after radiation therapy, clinical supervision of the patient is done according to response of the treatment. Now coming to the types of radiation therapy, it can be delivered in two ways, that externally or internally. External beam radiation therapy delivers radiation using linear accelerators, and internal radiation therapy called brachytherapy or seed implants involves placing radioactive sources inside the patient. The type of treatment used will depend on the location, size, and type of the cancer. This is the flow chart. That is teletherapy means external beam radiotherapy. Tele means it is a far source is far from the patient. It have different names, that is 3D conformal RT, intensity modulated RT, image guided radiotherapy, adaptive radiotherapy, or tomotherapy. The other characteristic is stereotactic radiotherapy, which is given by gamma knife or cyber knife, and the other portion is brachytherapy. That is brachy means near. So the source is placed near the tumor and radiation treatment is given. Now, first of all, coming to the external beam therapy, the name suggests that the source is external to the patient. Most of the external therapies are given by the X-rays. So if we are using X-rays with low energy, that is in the range of kV, it can treat superficial tumors. But for deep-seated tumors like central head and neck tumors or brain tumors or pelvic tumors, lung, then esophageal tumors, we have to increase our energies. So the most of the linear accelerators uses mega voltage radiation therapy. So the range of the mega voltage is from 4 to 20 MB. So it has an advantage of higher penetration and higher disease rate to the tumor. The adding advantage is it spares the skin and absorb dose is increased with depth. So according to the energy, the maximum energy is given to the deep-seated tumors. Other availables are again another than X-rays are proton, which are recent advances, which allows doctors to better focus on the dose on the tumor with the potential reduced to dose to the nearby healthy tissues. And the main is stereotactic radiotherapy. It is called sometimes also called stereotactic radiosurgery. This technique allows the radiation oncologist to precisely focus beam radiation to destroy certain tumors, mainly the cranial tumors, when it is located centrally near the brain stem, or we have to spare the eyes, lens, cochlea. So stereotactic radiotherapy is commonly used. Other alternative names are given by gamma knife or cyber knife. These are the cranial immobilization device when we are giving stereotactic radiosurgery. And these are some immobilization devices which is used in head and neck cancers. This is a type of backlog which are used in pelvic tumors or thoracic tumors to immobilize the patient, so that when we are taking first simulation of that is first CT scan of the patient, The treatment will be delivered during whole treatment period, that is 1.5, around 1 to 1.5 months. Patient is immobilized in the same position, and we have planned this patient in the same position. So our target is with sub-millimeter accuracy, and mainly target the tumor and sparing the normal tissues. Then other is brachytherapy, that is internal radiation. It is a form of radiation treatment where the radiation sources are placed within or close to the target, and it allows minimum dose to normal tissues because it has a sharp dose follow, and it gives the maximum dose within 5 millimeter margin. The radioactive sources are used are thin wires, rods, or capsules and seeds, and these can be either permanent or temporary. What are the indications? That cervical cases, palate cases, or breast cases, we can give brachytherapy. According to the site, it can be intracavitary, that is where cavity is available, that is cervical cancers, bronchial cancer, esophageal cancers. When it is radioactive materials are inserted in the tissues, it is called interstitial brachytherapy. In case of breast cancer, tongue cancer, floor of mouth, or anal canal cancers. And surface tumors like skin and palate, we can use surface mold to treat the tumor. Now coming to the side effects, the most common side effect is skin tenderness or skin reactions, which are generally limited to the area receiving the radiation. Unlike chemotherapy, radiation usually doesn't cause any hair loss or nausea, and most side effects begin during the second or third week of treatment, which may last for several weeks after the final treatment. Now coming to our department, this is our cancer OPD and radiation oncology department, which is situated in SSG hospital. This is our wards. We have 30 bedded cancer patients ward, where we are giving chemotherapy and post-operative care during the treatment. This is our 4D CT simulator machine. This is the patient lying with this green one is the immobilization or fit mask. During the treatment, we have to first position this patient, and this CT scan machine is not an ordinary CT scan machine. It is all simulated. It simulates the treatment. So this is a black couch, which is same as the treatment couch. So when we are doing the CT scan, the position of the patient is same at the time of CT scan and at the time of whole treatment. This is our treatment planning room, where we are first of all doing contours. In contours, we are first of all contour the target, that is the area of interest. Then sparing organs, that are spinal cord, brain stem, then parotids in case of head and neck, and in case of cervical cancers, we are the normal organs are rectum and bladder mostly. In case of breast, lung, and heart can be spared during the treatment. This is our linear accelerator machine. Then it compares the old era to recent era. That is, first of all, it was given on cobalt unit. It is called 2D radiation therapy. That is two-dimensional radiotherapy. It shows that in head and neck cancer, if the target is somewhat located here, and we have to treat the tumor. So the fields come from this side and this side. So whatever the organs comes in between the field, they receive the same dose. So the normal organs and the tumor receive the same dose. So patient get more side effects. With the recent advances, it comes to 3D CRT, when we can spare some these organs. And according to with recent advances, IMRT, that is intensity modulated radiotherapy, comes. So we can spare the parotid in head and neck cases in both sides, and we can target the main area with maximum dose. These are some head and neck IMRT planning. This is the main, that blue one is the target area where the disease is located. So the red shows that it is the maximum dose which is given to the target, and this is the suboptimal dose where the nodal area or sub microscopic disease are present during the treatment. This is the brainstem, this is the spinal cord, which we are sparing during the treatment. This is a case of head and neck where that brown one is the parotid, and you can see that yellow marking. It is our primary area that we are treating. This is the parotid of opposite side, but due to the location of the tumor on that side, we cannot spare this parotid. But by the advancement, we can spare the opposite parotid with somewhat minimal complications. This is the GYNEC planning in case of cervix. This is a case of cervix. So this is the tumor, that is red one. This is the bladder, and this is the rectum. So the planning is according to the if we are giving the 2D treatment, beam will be fired from anterior side and posterior side. So there is no sparing of the rectum and bladder in previously era, but with recent advances, we can target the main cervical area and the nearby spreading lymph nodes. So we can spare rectum and bladder as well. This is the breast planning. This is the area of interest for our breast planning. We can spare lungs on same side and spare almost whole of the lung on opposite side and contralateral breast also. We can spare heart with some recent technologies, that is deep breath hold technique. So when we are when we instructed the patient to take deep breath, heart comes down. So we can achieve more less dose to the heart. This is our HDR brachytherapy unit, where we from where we can give radiation to the local part. That is in case of cervix or when we have planned any brachytherapy in head and neck cancers. These are the cervical implants which are inserted during the cervical treatment. This is cervical brachytherapy planning. When we are giving, in case of CS cervix, first of all, we are giving around 45 gray externally. So the maximum dose, tolerable dose for the rectum and bladder is around 45 to 50 gray. Beyond that, we can see toxicities to the bladder and rectum. And cervical cancer is the most beneficial case where radiation have main role. So if we are giving with radiation whole dose from external beam, we can have a maximum bladder and bowel toxicity. So a patient survives, but they have a maximum toxicity like cystitis and bleeding PR. So we can improve the quality of life by giving 50 gray, around 50 gray externally, and brachytherapy by another, that is 30 to 30 gray. So it is that blue one is the main area where we have to given the dose, and it is the advantage of brachytherapy that within 5 millimeter of area, the dose is sharp dose follow-up, and the maximum tumor, that is the green one. This is the our area of interest where we are giving the maximum dose with sparing. This is the bladder. So we are giving minimum dose to the bladder, and it is the rectum. So when the patient comes to the follow-up, they have a minimum toxicity to the bladder and rectum. This is the ideal treatment after brachytherapy. These are another cervical brachytherapy in case of post-operative cases, where central vaginal cylinders are inserted and the dose is given to the nearby area within 5 millimeter. Till now, we are treating around 40 patients per day on our linear accelerator machine, and we have treated around 350 patients in last 1.5 years. We have also treated patients with brachytherapy with better quality of life. Now coming to our tricky patients, we have treated most of the cases, but the tricky patients I have to discuss. This is a case of cancer leaf. with T2 lesion. The bluish mark is showing that around 1 to 1.5 centimeter tumor is located on the upper lip. Initially, we have given 50 grade 25 fraction to local area and nodal area to control the microscopic spread. After that, we have done brachytherapy, in which with the help of our ENT surgeons, we have inserted needles and then catheters nearby the lip area and given dose by our STR brachytherapy unit. And this is the final result that with almost complete response after completion of the treatment. This is the case of basal cell carcinoma and 75 years old male patient. It was first presented with a tip of the nose lesion. We have planned whole external beam radiotherapy by making a mold which covers only the nose area and sparing the eyes. And this is the final result that it shows there is no any skin reactions and complete response over the nasal tip. We have also government initiative of CM Setu, and we have tied up with one hemato-oncologist that have given help, and we have given Hodgkin's disease recurrence patient. We have treated these stem cell transplantation and have a follow-up after 3 months PET scan, which shows complete response. And it was given almost free of cost. You can hear that around stem cell transplantation in outside, it costs many around 10 to 12 lakhs per patient treatment. But we are treating here as a free of cost or with minimal cost. So when the poor patients who need curative treatment, they can be referred to our hospital. This is a case of it is a video of brachytherapy which we have done. This is the case which I have showed previously. Initially, we have marked the tumor and the margin of around 5 millimeters. Then these are the needles and buttons. These needles are inserted into the patient. The needles are inserted like that. There will be spacing around 5 millimeter. So after surgery, there would be minimal edema and it can be subsided. And according to our physicist and our ENT surgeon, we have inserted these needles. This is the final impression. And after that, we have inserted the catheters. The needle will be removed by placing the catheters like this. By pulling the needle will be removed and the catheter take place the side. These buttons are included, so we can mark the patient from where to where we have to treat this green button, yellow button, and this is a one catheter which is this is that green catheter. So according to when we are planning, we first locate the catheters, and with this catheter, the radiation dose is given to the local area. This is the other case of tongue brachytherapy, what we have done. In this case, it is also a T2 lesion, but just involving floor of mouth. So the patient preferred to take radiation. In this case, we have also marked the radius. First of all, marking the tumor, And after inserting the needles, and it is replaced with catheters. And this is the final impression before giving the radiation. This is the case of PALATE. He is also a around 75 years of old patient, and there is a local lesion. In this case, we have also given 50 grade 25 fraction, and after that, we have given the mold treatment, and this is the final response. And patient having 6 months normal follow. This is we have given brachytherapy, and with the help of our dentist, we have made a mold protocol, and these are the catheters which are inserted in the patient. But during the treatment, these catheters are connected to the channels of the machine, that is our SDR brachytherapy unit, and the source size is around 3 millimeter. So from machine, it is situated in the machine, but it is controlled from outside, that is remotely controlled. When we ask the source to go, it goes from this channel and traversing to this channel to patient main location area, and stay for some time, give the particular dose which we have planned, and again it is going back to the machine. Then it will go from this channel and giving staying somewhere and giving some dose, and the process repeated for few times, around few minutes. This is our radiation oncology team, and this is our happy patient. Finally, the question is radiation therapy safe? So many advances have been made in field to ensure it remains safe and effective, and multiple healthcare professionals develop and review the treatment plan to ensure that the target area is receiving the maximum dose, and the treatment plan and equipment are constantly checked to ensure proper treatment is being given. Thank you.
Thank you, Dr. Divyesh. That was a beautiful journey. We are all very happy. Most of us are Baroda Medical College and SSG Hospital alumni. So it is so heartening to see that something so good is being done in our own institute to very non-affording patients. We all know that cancer treatment is very costly, and you're doing a wonderful job. So compliments and congratulations from all of us who are watching this session. I have a question. We often hear that whenever a new setup comes up, they say that this is the first of its kind, radiation therapy unit that we have. I mean, what are the various types of radiation therapy units, and how are they ranked in terms of their efficacy?
This is according to their recent technologies available, and we have the latest. And previously we have cobalt unit. So it is like a 2D treatment where it is a blind treatment that we have to fire the beam and see the response. But this in recent advances, we have a computer planning. So we can see that what area receive which dose. And according to the plan, we have iterative plan. That is, if first plan is not suitable for us, we can give computer another command that first spare the parotid first, spinal cord first, and brainstem first, or when we have the lesion located near the eye, so we can spare that organ and giving the maximum dose to the tumor. Sometimes we have to compromise the normal organs also to treat the tumor. But our first target is tumor, and that we have to cure the disease. And after the second option is to spare the normal organs.
Do you accept other patients? I mean, those who are treated for surgery or chemotherapy somewhere else, and they want radiation therapy at SSG hospital. Is that okay? Or
yeah. We are treating many patients who are referred from our private setups, and they are taking good advantage of our center.
All procedures very sorry. Sorry, Jagdish, please go ahead.
You use isotopes for cobalt therapy and those needles. Yeah, some problem.
Yeah, his connection seems to be unstable.
Yeah.
Initially, we have a cobalt 60 source.
Yeah.
Divyeshkumar, we can't hear you well. I think your connection has become very unstable. No, you are muted. Please unmute.
Okay.
Yeah. Now we can hear you.
Okay.
Divyeshkumar, you can answer the question. We didn't hear your answer because your connection was unstable. So Jagdish had asked about cobalt isotope.
Okay. Previously, we are using the cobalt 60 source, and the machine is installed in around 1995. But due to recent guidelines from the AERB that is situated in Bombay, that old cobalt units and old sources will be decommissioned. So we have decommissioned our unit, and we have done this all brachytherapy with iridium 192 source, which is latestly installed in our department. And the cases which I have shown that all are treated with iridium 192 source. And the linear accelerator uses the X-rays. So the using of radioisotopes is limited to the brachytherapy area.
From where you source isotopes? Baba Atomic?
From Baba BRC and AERB.
Okay.
And our company, our supplier is Varian. So they are purchasing the source, I think, from Germany. And it is a characteristic of that company that BRC is not manufacturing till now.
Are these procedures very painful, Divyeshkumar?
No. That during the implant insertion, we are giving the spinal anesthesia. And that cases which have shown that is tongue brachytherapy and lip brachytherapy, these are done in ENT operation theater. So during this time, patient was under GA, and after that, coming out of the anesthesia, there is no pain at all.
How long these needles are kept inside?
According to the plan of the dose, we are giving these needles dose in day 2 times. So the needles are kept around 2 to 3 days according to the dose plan. So we have already given 50 gray 25 fraction externally. So the remaining dose, that is around 20 to 30 gray, which will be given by brachytherapy to boost the local tumor.
So if there are not any other questions or comment, we can close the session here. Thank you very much, Divyeshkumar, once again.
Okay.
For sparing your time to be with us in early morning.
My pleasure.
Thank you so much. And thanks all of you who are attending this session. We'll meet next Saturday again. So thank you and goodbye.
Okay.